Okay, so this is Lwidiko, and we will be talking about malaria in terms of the biology of the disease, the pathology of the disease, how it makes you sick, and the symptomatology in terms of how does a disease present itself when you are infected. So basically, I work you through the introduction and how the parasites in the biology is taxonomy, the parasite biology, the life cycle of the parasite, um, the pathogenesis, clinical features, and we'll see some references. So basically, malaria is the most important of tropical diseases that are known to man. It has been discovered in the bodies of Egyptian mummies that are more than 3,000 years before Christ. There's some history where 200 years before Christ in China, medicine that people were presenting with fever-like symptoms that are typical of malaria. And it currently remains, since those many years before Christ was born to now, as a problem in many tropical areas, especially in sub-Saharan Africa, where it is affecting children at the age of 5 years mostly, pregnant women and other patients with conditions like, that are immunocompromised like HIV, or travelers who've never had exposure to the parasite. You would notice that all these groups are groups of people who have not had exposure to the parasite, children and under the age of 5, pregnant women, and these HIV compromised people. I think it's important to mention here that the epidemiology is changing right now. So we are now starting to see a shift in epidemiology from children under 5 years of age to being children under the age of 10 years. Preschool age are the ones that are mostly also affected right now. And I will explain to you the reasons in a moment. So the more than several species of Plasmodium, which can infect many animal species, including birds, there's avian malaria, there's reptiles and various mammals. But the most important ones are 5 species that are known to infect man. So there is Plasmodium malariae, which has a typical presentation of quartan malaria. And there is also Plasmodium vivax, which is known to cause the benign version of the disease, and it's known as tertian malaria. And there's also Plasmodium falciparum, which is known as the causing malignant tertian malaria, and malignant meaning is much more deadly version of the disease. And there's Plasmodium ovale, which is also causing tertian malaria. These tertian, quartan, these are the intervals between one episode of fever to the next. And there's Plasmodium nosai, which is mostly known to infect mosquitoes that bite animals to those, and then they come to bite human beings, mostly monkeys, macaque monkeys. This is Plasmodium nosai. Human-to-human transmission has not been established yet. So in terms of a classification, this disease has apicomplexa in terms of phylum, and then they belong into this. Apicomplexa is an important feature of the disease because it is a special feature of the parasite itself and how it is attaching to the red blood cells. But then the class Sporozoacida, and is in family Plasmodiidae, and genus Plasmodium, with the several species that I've mentioned before. So the Plasmodium falciparum is the one that causes severe malaria because it's known to multiply rapidly in the blood and can cause situations that are anemia. And we will see this in the when we talk about the life cycle of the Plasmodium falciparum. But infected parasites can clog even small blood vessels, and then they start to cause things in the brain, like rosetting and brain ischemia and cerebral malaria. Red blood cells, they're usually not enlarged. An incubation period for Plasmodium falciparum malaria is the shortest, between 8 and 14 days. So when the parasite gets injected to you by the mosquito, it takes it 8 to 14, 11, 14 days to end up for you before you start causing symptoms. And the periodicity of 36 to 48 hours, in terms of after every 36 to 48 hours, you start developing symptoms of malaria, that like fever and things like that. This typical feature of Maurer's dots. This is when you're looking at the parasite under a microscope. This is something you'll be able to see. And it's a significant cause of abortion, stillbirth, and even death among non-immune pregnant women. So this is an important disease, especially for this group. So this illustration is showing you morphology of different stages of the Plasmodium falciparum life cycle in thin blood films. You would see in number 1, it shows you like ring-like structures, which is these are within the these are trophozoite forms. These are feeding forms, or called ring forms. And number 2, these are developing trophozoites. Then the feeding forms are starting to develop more, and these are rarely seen in peripheral blood, but they start to give you like a ring form. And you will notice that there's like a blue shape and a dot that's ring-like in image number 2. And then image number 3 shows you matured, immature schizonts. These are very difficult to see in peripheral blood, where you usually take the smears. And mature schizonts are typical in the stage number 4, which almost fill the entire red blood cell. And then microgametes, which number 5, they start to form. And then you can be able to see these ones, and they're being picked up by mosquitoes. And they usually appear within 7 to 12 days after the infection. So then the next one is Plasmodium vivax, together with Plasmodium ovale. Both of these have a dormant liver stage. And I will, again, just if you bear with me in a moment, in the life cycle, you'll see that when the parasite is injected by a mosquito, the first thing that it does, it goes into your liver. And when it goes to the liver, it can start to divide there to form merozoites. And in these species of P. vivax and P. ovale, they tend to form dormant stages, which are known as hypnozoites, which don't divide, and then they can stay there several months or sometimes even years after being infected with mosquito bite, which is causing a relapse. And these P. vivax and ovale are not known to be prevalent especially in Western Africa. You might ask yourself, why is this the case? And we'll probably answer this later. But there is a reason why people, especially from the western part of Africa, don't get high levels of P. vivax and P. ovale. And the incubation period is like 10 to 17 days. And the patients have the red blood cells that are infected enlarged, and they give these typical schuffner's dots, which you're going to see them in a moment. So schizonts usually contain 12 to 24 merozoites, and these are in the merozoites in the liver. Then they divide, and then they invade the reticulocytes, which are red blood systems, and then they start to cause the pathology, as I've mentioned. So this is an illustration. You would see that different stages of vivax in thin blood film of a person. And number 1 is early trophozoites. These are also typical ring forms, and you would see that as they develop, they become large and irregular, and then they lead to irregular shapes of the red blood cells, as you can see here. And this distortment, they give you this vacuole that is inside the cell that's much more prominent, but they distort the shape of the red blood cell generally. Now, immature schizonts, which are in number 3 here, they give an amoeboid form and almost fill the entire red blood cells. And mature schizons that are seen in number 4 almost fill an entire red blood cell again with schizons. And gametocytes, these you can see in number 5 and number 6. They're usually large in number, can have then they take 3 to 5 days. But compared to Plasmodium falciparum, whose gametocytes were banana-shaped, as you could see, I could show you here. These are banana-shaped gametocytes of Plasmodium falciparum. The gametocytes of ovale and vivax are not just quite round and typical of that shape. And now next to the next species, which is widely distributed in the tropical, is much more prevalent. If you remember, vivax and ovale, we said they're not very much prevalent in Western Africa. Malaria is widely distributed in the tropics, and the incubation period for this disease is between 10 to 17 days. But the trophozoites, they make also the red blood cells to become bigger than normal. They enlarge, and then the gametocytes are slightly enlarged and then stippled. Schizonts usually are smaller than the red blood cells, and they contain 6 to 12 merozoites, and then have brown greenish central pigmentation. You're going to appreciate these images more when we get to see the slides presentation tomorrow. So in the case of malaria, infected red blood cells are not enlarged, and sometimes they become smaller than the red blood cells. And the low density of infection in the red blood cells, so usually less than 0.2% of the red blood cells are parasitized in the case of malaria. This is why the disease pattern is less aggressive compared to Plasmodium falciparum. And the trophozoites are usually heavily pigmented. They stain very deeply than normal, and they don't have any inclusions like a dots or like the Maurer's dots or schuffner's dots are not present in malaria. And usually are low, they have low parasitemia, as I've seen, is like only 0.2% of the red blood cells are usually parasitized. Gametocytes contain large amount of black pigment chromatin, and the malaria causes long-lasting infection, sometimes even chronic infection that can last even in a lifetime. And some chronically infected patients with malaria can have serious complications such as nephrotic syndrome and the likes, but the level of fatality of this malaria is quite low compared to fatality rate for Plasmodium falciparum, and they tend to invade old erythrocytes. This is how the parasite looks like generally, with the polar rings in the front. And this is an apicoplast, which actually makes it belong to the apicocomplex category. And it has a nucleus, of course, and it has other vesicles. And all these are important because the falciparum, for example, contains cytostome, which is a large double membrane structure that connects this parasite to the red cell's cytoplasm. And this cytostome, the importance of this cytostome is to make sure that the parasite attaches and gets inside the red blood cell cytoplasm. And falciparum uses glucose and glycerol as a major source of carbon. And the cytoplasm of the red blood cells that has much more amount of hemoglobin, more than 95% of the hemoglobin, is the one that's used to generate amino acids that are used for the parasites. Plasmodium falciparum is known to have to be an AT-rich parasite, and the remainder of amino acids is actually dependent from the host. So hemoglobin becomes a source of amino acids for the parasite. And this is important because you would get to see some of the drugs such as chloroquine was working to stop the breakdown of hemoglobin and accumulates hemozoin, which is toxic, and then kills the parasite. But we'll talk more of this when we're talking about the disease, the drugs, and the drugs, how they work. So energy production is done through anaerobic glycolysis, where the parasite converts pyruvate to lactate. And natural ecology of malaria involves malaria parasites infecting successively two different hosts. So human and female anopheline mosquitoes. And we're also going to talk about the vector, which is mosquito host today. So this is a life cycle generally of the malaria and the different stages that are involved. I'd like you to focus on here, where the mosquito, when it takes a blood meal to infect a human being, and then the red blood cells will be affected later, but immediately the parasites jump all the way into the liver cells. They go all the way into the liver, and then they will be stored there, and they will incubate there. This is the exoerythrocytic cycle, which is important incubation period before the parasite is ready to get out as Schizonts and then start to infect the red blood cells, which is known as the erythrocytic cycle. So in this stage, if it is depending on a species, for some species could develop hypnozoites and would stay dormant in the liver, and some species would continue the circulation into the blood. Now, this stage is very important because before the red blood, the liver cells are infected, at this point, the parasites can be stopped. So this is a trigger, or one of the most important vaccines of malaria created. These are sporozoites vaccines. These sporozoites that are injected into the mosquito can be stopped to enter in the liver cells, hence prevent the continued of infection in the human being. So this is where the current vaccines that are working on the sporozoite vaccines work to prevent this stage. And then once the parasite enters the red blood cells circulation, they'll be infecting the red blood cells, and then they would mature in there as trophozoites. Once they mature, they lead to cause Schizonts, and then the Schizonts rupture. During this rupture, this is where all the cytokines and inflammatory mediators are released, and the person starts to feel sick, and then the cycle continues, right? So every 48 hours, the red blood cells get invaded with new trophozoites. They eat in these red blood cells, they mature, they replicate, they form Schizont, they rupture again. So this one will be like with malaria from falciparum will take at least 48 hours, 36 to 48 hours to cause the continued clinical symptoms of malaria. After this has gone on for several cycles, a portion, let's say less than 10% of these parasites, they would convert into gametocytes. Once they become gametocytes, they would, get under the skin or get incubated, where they can be picked up later on by mosquitoes to continue the transmission. Once they're picked up by the mosquitoes, when the mosquito comes for another blood meal, the mosquito will eat these gametocytes. And the gametocytes will definitely go directly into the stomach. And the difference in temperature between the body and the body of a human being, which is 37 degrees Celsius, to the mosquito body, which is lower than that, would trigger formations of actual gametes, microgametes, like the male gametes will exflagellate, so from flagella, and start to swim, and then enter the female macrogamete, and then they will reproduce to form something called as ookinet. The ookinet then all is in the abdomen of the parasite, and then they would start to, the ookinet would walk outside, will crawl outside the epithelium of the gut of the parasite, and then it would form some things known as oocysts, and then the oocysts would wait and mature, and they would rupture outside the coelom of the parasite of the mosquito, and then these sporozoites would migrate all the way to the liver, to the salivary glands of the mosquito, and then when the mosquito gets to bite you again, the life cycle continues. Great. So all this description right now is what I've been saying right now, that during a blood meal, the infected mosquitoes inoculate the sporozoites into human hosts, and then the sporozoites infect the liver cells, and they develop into mature schizonts, and then eventually released merozoites. And in vivax and ovale, they'll give you hypnozoites, as I've mentioned, and these are dormant stages. They can stay over years. Initial replication can be in the liver. It's known as exoerythrocytic schizogony, which is outside the red blood cells, and then where they will undergo asexual multiplication in the erythrocytes as the red blood cell schizogony or erythrocytic schizogony. And these descriptions is basically the same thing that goes on, where they would differentiate into gametocytes, and they would move from the gametocytes, they'll multiply into the differentiate into gametocytes and microgametes in male and female. So sexual reproduction of the parasite, male and female, happens inside the mosquito, and asexual reproduction happens in a human being. So these parasites multiplication in the zone as progonic cycle, and then they continue as such. And this is just a repetition of what I've said, that the oocysts grow and rupture in sporozoites and then continue the life cycle. This is another version of this life cycle. So there are no known toxins that have been identified from this Plasmodium species, but then they induce the disease by release of cytokines, that, as I mentioned, which cause similar pathology as what we'd see in bacteria endotoxins. So symptoms and pathology of malaria occur during the erythrocytic stage. So pathological changes that are associated with all types of malaria have certain features in common, but the most common features is in the falciparum, which is most fatal. The reticuloendothelial system is activated, and this activation of the reticuloendothelial system is caused by the rupture of the infected red blood cells, and they trigger the inflammatory response of the host. And malaria antigens that are related to IgE complexes also activate the cytokine release response. Also, the cell macrophages and monocytes are stimulated to release some cytokines like TNF, interleukins, and interferon gammas, which produce pro-inflammatory cytokines, which these are the ones that trigger you to develop fever and things like that. So these are the ones that are responsible for most of the symptoms in the human beings. And the liver and the spleen, usually they are the ones that are responsible to clear up these parasites. And while they're trying to clear the parasites, they're working hard to clear the parasites, the spleen, for example, they start to increase in size because it's known as hyperplasia. And then the person who would have, or a child who would have chronic malaria infection would develop hypersplenism, or an enlarged spleen and an enlarged liver. This is a common feature in especially people or children with a chronic malaria infection. Acute infections, usually, a person would have like a soft enlarged spleen, but this is not really common for acute infections. But then eventually you might end up rupturing these spleen, especially in much more prolonged infection. And the macrophages that are within the spleen, the liver, they exhibit phagocytosis, and they help to clear the malaria parasites. So When the life cycle continues and the red blood cells get destroyed, with the increase in destruction of red blood cells, there's also an increased turnover of iron and blood pigments. And this one usually leads to production of new hemoglobin. At the same time, leads to chronic anemia, and this is not good, especially for children and pregnant women who really depend on the hemoglobin for continued blood transmission, oxygen transmission within the body. So continued activity of malaria leads to firm and fibrotic spleen that sometimes, if it doesn't rupture, the fibrotic spleen shrinks and back to normal size, but then it becomes very, very dysfunctional. So hepatic dysfunctional is minimal, showing only slight elevation of bilirubin and liver enzymes. So there's little to no reaction to erythrocytic cells. Again, so with continued malaria infection, anemia develops and varies to a greater degree depending on the degree of destruction of the red cells. Complement system is activated, and then it consumes the complement components in using the classical pathways, and immune complexes are usually formed, and then they're deposited in the kidneys. So this is the case where there's severe malaria, where these immune complexes are deposited in the kidneys, and then you get to something called as black water fever, where there's a huge amount of hemolysis, meaning the red blood cells are being broken down to the larger extent, and then they are being disposed even through urine. And this was known as the black water fever. This is a severe version of the disease. So this brings us to the symptomatology, where we would see sometimes it varies depending on the species. Incubation can vary from few days to 30 days. Small number of parasites are actually present in the circulation a day or two before the symptoms begin. And as the number of parasites increase, the infected individual begin to experience several symptoms such as headache, weakness and lassitude, vague pains, some joint pains, bone pains, chilly sensations, and even fever. Within a few days of regular episodes of chills and fever become more prominent, and other symptoms may start to develop. Muscle aches and pains and headaches, they can persist more. So these are quite constitutional symptoms for a patient who is infected with malaria, and different, not significantly from other diseases. So there's something known as malaria paroxysms. These are episodes of malaria which happens every end of the schizogonic cycle. Schizogonic cycle is when the red blood, when the merozoites mature, the schizonts enter the pigments into the erythrocytes debris and erupt the infected red blood cells to release them into circulation, the one I just mentioned. These paroxysms are the most important and the most clinical presentable diseases. They can begin, with a cold stage in up to an hour, and then chilly sensations, and then progress to very, very teeth chattering, shaking, and basically trembling from the fever, and then the cycle continues like that. In some cases, even the peripheral blood vessels can constricted, and then you can get cyanotic lead nails and lips. At the end of the cold stage, the body temperature begins to mount rapidly, leading to the hot stage, which can last up to from 6 to 12 hours. You can get to nausea, even vomiting, especially during this place, and the fever can reach up to 41 degrees, 39 to 41 degrees. And this is really where a person presents himself as a clinical case of malaria. And because of the high fevers, the patient can present with euphoria, and the sweating, and then by the way, after that, the temperature starts to fall, headache disappears. In a few hours, the patient becomes exhausted and symptomless. And then, as I said, it takes about 36 to 48 hours. The person might feel well before the next episode of paroxysm to occur again. So even with malaria, someone might feel very sick and then feel good, and then very sick again, and then very good. These regular intervals could be synchronized, but for Plasmodium falciparum, they could be asynchronized in terms of, it could be sometimes within 12 hours, is symptom free, and then you get symptoms, or sometimes more than that, depending on different species of parasites that reach the maturity at that time, then released in this circulation. So tolerance phenomena appears to operate in the sense that at the higher degrees of parasitemia, the infection no longer produces the degree of fever than it was in early stages. So when you start to develop symptoms at early stage, the very first cycles, the fever becomes much higher. But then the more you rupture again red blood cells, the tendency to have high fever can kind of like lowers. And especially this is important for people who have developed immunity against parasite of the malaria parasite, can even have without even fever, asymptomatic infections. So this is can be within, if you know, can continue for 2 weeks or more, and then the spleen gets bigger, and then you can even feel it. And this has also been I mentioned this before. The white blood cells, which are quite important, they can be fluctuating, and especially during these episodes, but in terms of total leukocytes, but generally they would remain within the normal limits. And thrombocytopenia is common because anemia is usually only moderate during primary attack, but in chronic phase, the anemia becomes much more prevalent. And sometimes there's this known as drug-induced hemolytic processes, such as black water fever, or when you use medications such as artemisinin, which tend to cause delayed anemia, which is when the artemisinin kill all the parasites, but the infected red blood cells still would be hemolyzed by the spleen, so they cause delayed anemia. As again, anemia can be more chronic with chronic malaria. The massive black water fever, hemoglobinuria, it's when you can have the Coca-Cola colored urine, or like a dark urine color, because of the acute respiratory hemolysis of the red blood cells. And because you've now reduced red blood cells, your capacity to transport oxygen in your bodies becomes lower. You end up with acute respiratory distress syndrome, and even severe gastrointestinal symptoms can occur. With severe malaria, you can get to affect kidneys, and kidney function can be infected with with severe malaria, but usually acute version of malaria, sometimes you might not have more evident kidney disruptions, although different evidence of transient glomerulonephritis can occur in some patients. Cerebral type of malaria is characterized by headache, delirium, psychotic behaviors, and even convulsions. So altered level of consciousness is a feature. And then eventually you find yourself in stupor, and then you end up in coma with malaria. So malaria is quite deadly if not treated early. Issues like vomiting, abdominal pain, and diarrhea are also common symptoms which can also seen. Also, pulmonary edema can also be presentable, cyanosis, also because of ruptured red blood cells, you could have impaired oxygen transmission in the blood. So there are cases where you have asymptomatic malaria infections where because of someone has been previously infected with malaria, they can develop something known as like premonition or immunity against malaria. So even if someone has parasitemia, they don't develop typical symptoms of malaria. And if you do molecular tools, use molecular tools to diagnose, you can find that there's people with malaria but don't have symptoms are important reservoirs of the parasites, and especially in places where malaria is low in endemicity. Right, so that's the first part where we're talking about malaria biology, the disease, and symptomatology. You're welcome if you have any questions.